This conference will now be recorded.
Welcome in, everybody. We are going to be talking about geriatrics and the aging population in correlation in Chapter 39 of your guys' textbooks. Now, our geriatric population does account for the majority of our calls. Variety of different reasons behind that, but the majority is the fact that we have deteriorating health. After we turn 30, every year after that, our organ productivity loses about 1%. So if you're to look at a 99-year-old, they have roughly 69% of their organs are not as effective as the adolescent or the younger population. So the objectives for today, we are going to be looking at all of these lectures. So first, we're looking at the geriatric population. So the geriatric population, 30-year-old man versus another 30-year-old man when we're looking at this. So the majority of the time, these two individuals are going to be pretty healthy, and a lot of their medical history is going to be pretty similar to that between the two of them. Now, if we compare an 80-year-old man versus an 80-year-old man, now these two health histories can be drastically different from one another. When we're looking at statistics too, as far as our geriatric population, in the year 2000, 13% of the world's population was 65 and older. So 2000, 19 years ago. Now, if we look at earlier statistics and what we could foresee in the future, 2030, it's going to be an estimated that we have an increase of 7%. So 20% of the world's population is going to be 65 and older. So with new technology, new advances in healthcare, we're starting to see that age range for our patients continuously getting older at that point. Now, if we break it down by country, we can see our population. So the United States roughly is right in the middle. So where are our calls located at for geriatric patients? Where are these individuals living? There is a couple of different areas that they could currently be residing at. So within the age range of 65 to 74, about 1.1% are living in institutions. So an institution is going to be classified as a nursing home, assisted living, something along those lines where you have 24/7 care staff on scene that are actually taking care of these individuals. In between the age range of 75 to 84, 4.5% live in these institutions. Now, quite the change as far as looking at how much of our population is 65 and older, and then digging into how much or how many of these individuals are actually living in those institutions. Now, once the age range progresses and we're looking at individuals who are 85 and older, this is where about 19% of these individuals are living within the confines of a nursing home or an assisted living facility. So breaking down these institutions, this is what we're looking at. Now, the majority of the population are going to be living in nursing care or assisted living. Now, there is a population that's going to be residing within some type of hospice care facility. Now, with our nursing care and our assisted living facilities, the amount of time that these individuals actually spend there is quite a bit longer in comparison to our hospice care. Now, generally, somebody who is going to go into a hospice care facility, they are basically at the end of their lives, and generally they don't surpass living within that facility for longer than just a couple of months. Now, we can also see a large population are actually receiving home health care. And again, this is becoming more and more common, more and more popular for the individuals who maybe they only need a couple of things in order for them to sustain their normal routine and they just need that extra help. And that's why we're seeing quite a bit more as far as home healthcare individuals. Now, home healthcare, this does not correlate into our population statistics as far as who's actually living in an institution. These would be people who are qualified as far as saying that they are living at home. Now, the 8 most common conditions that older patients are going to have and how they relate to us as EMS providers. So 40% of the older population, so this is going to be 65 and older, are going to be suffering from some form of arthritis. So we're going to see a lack of mobility with these individuals. We can see an increase in pain and then also poor circulation as well. Second most common is going to be hypertension. So 36% of the population, 65 and older, suffer from high blood pressure. So how that correlates to us is we can see a lot of different things that are going to negatively affect the cardiovascular system because they're constantly running at a high blood pressure. They don't have they do have poor circulation. And then also they are much more prone to cardiovascular disease, arterial disease from that constant hypertension state. Next, 30% of the population suffers from hearing impairment, so it can be rather difficult to actually perform a good, thorough assessment on these patients. You have to tailor your assessment and communication techniques when you are dealing with them. Now, never assume that since you're dealing with a geriatric individual that they do suffer from hearing impairment, because you just look like an ass if you walk into that scene and start yelling because you think that they can't hear you properly. So ask if they do have any issues with hearing, and oftentimes our patients will say, you know, I hear better on the left side. So try and direct your voice to that left side of that patient. 27% suffer from heart disease. So heart disease is going to be a blanket term. So maybe they have had MIs in the past. Maybe they suffer from coronary artery disease, what have you, but there is a lot of different issues with that heart disease component when we are dealing with these patients. So some common medications that we might see for individuals who suffer from some type of heart disease is going to be our daily aspirin. Maybe they take nitro. Next, 18% suffer from some type of orthopedic impairment. And again, this really correlates to our arthritis too. So difficulty moving around, much more prone to falls at this point. And then how they reside in their homes too, if they are still living at home, is oftentimes they have an abundance amount of furniture, throw rugs, what have you. There's a lot of trip hazards in there. And this is where we can correlate our continuing education or our community involvement in something like this, where we can actually give them guidance as far as how to better protect themselves when they are at home. You know, let's say we get called for a lift assist or called for a non-emergency issue. We can take the time and try and make them a little bit safer when they are residing at home. 17% suffer from some type of form of cataracts. So again, this makes it much more prone that these individuals are going to have falls or traumatic related incidences because they're not seen as well as the younger population. 12% suffer from sinusitis. This we're not going to get called to. This doesn't, drastically affect our EMS involvement, but it's just another thing, such as there might be a gas leak in the house and they aren't able to properly identify that there might be an abnormal odor in their house and that could create some type of toxicology emergency. And then 10% of these individuals suffer from diabetes as well. High blood sugar, low blood sugar, their body is kind of in a constant swing. Another thing we got to keep in mind for individuals who do suffer from diabetes in that geriatric population is we're going to talk about behavioral issues and psychological issues. These do run a high chance of suicide and suicide attempts within this population. And one of the things that individuals who are diabetics, who do have insulin handy, oftentimes they will actually take a large amount of insulin in order to drop their blood sugar for a suicide attempt. So here we can see that example of that arthritis, the differences within that anatomy scope. So when we are checking CMS or if we're doing our trauma assessments, very important that we are diving deeper into our sample history. Is this normal for you, for your hand to be in this position? Playing on this too, we do have different types of spinal curvature too for our geriatric population. So this makes it very difficult for us to properly C-collar and backboard a patient. So we can see the difference between a normal spine and then somebody who suffers from kyphosis. So we can see the void spaces if this individual on the right is actually in a supine position and we are putting them onto a backboard. We want to make sure that we're padding within those void spaces because it's going to be very uncomfortable for this patient to actually be C-collared and backboarded. Now, that's another reason why we don't see and are starting to get away from C-collaring and backboarding basically every patient. So we're starting to dive into research and data that's starting to show that we're almost overboarding our patients when we are looking at supine immobilization. So now we're going to dive deeper into anatomy and pathophysiology in correlation with the changes of ages. So we're going to talk about the skin system, respiratory, cardiovascular, nervous system, our different sensory changes, our psychological changes, renal system, musculoskeletal, and then also our immune system. So with that skin system, our skin is going to start to lose elasticity. It becomes thinner and drier, and it is more fragile. So when we are talking about these different systems, think of what these systems actually do for the body. So that skin system, first thing is it offers protection. So with that skin becoming drier, thinner, more fragile, it doesn't allow for the complete defense mechanism that we might be used to being younger individuals. So they're more prone to infection, viruses, bacteria, because that skin's not offering that first line in defense. Also, what else the skin system does is it regulates our water balance, and then it also provides proper body temperature. So again, this is another reason why our geriatric population constantly complains of being cold. When my grandmother and grandfather were still alive, I swear to God, they wore jackets even when it was 99 degrees outside. So with that subcutaneous layer, it becomes thinner, and this is another reason why they are much more prone to bruising too. So with that subcutaneous layer, this is where we're going to see those burst blood vessels, and then it's going to show on that top layer of that skin, that epidermis and that dermis. So elastin and collagen, both of these are chemicals, and both of these are going to decrease. So what these specific chemicals do within the skin system is one, offers for resiliency and elasticity, which is going to be our elastin. And then collagen is actually one of the chief chemical properties that make our skin strong. So with these two chemical properties decreasing over time, this is where we see that increase within that thinner, drier, and then less elastic skin. Next are sweat glands. That activity decreases. So what our sweat glands do is it helps regulate that body temperature of our patient. And again, this is going to be negatively affected as far as trying to regulate that body temperature for that system. Now, a lot of the people in the class might not remember the year 1994, but in 1994, there was a significant heat wave in the city of Chicago and in the Midwest area. And as a result, about 880 individuals actually died from that heat wave. A majority of that 880 people were the geriatric population because they couldn't really regulate their body system. And then also they don't drink as much water as they normally should. And we'll talk about that within the next few slides. Diminished capillary blood flow as well. And so again, when they get those injuries, it's difficult to actually start providing that defense mechanism and that healing mechanism for these individuals. So then we can see the difference between that younger generation with that skin system compared to our older generation, and we're dealing with much less basically trampoline effects for these individuals who get in traumatic incidences. And again, that geriatric population is much more prone to falls, so they don't have that cushion or that shock absorption system that the healthier, younger individuals do with that skin system. Next, we're going to be talking about the respiratory system. So within the respiratory system, our musculature of that upper airway weakens. So this creates quite a few different issues as far as these individuals are much more prone to infection from different types of viruses and bacteria. And then also they are much more prone to choking too, because they're not able to actually relieve that object if they do begin choking. We also have a change in bone and teeth, and that's where we see a lot of individuals who actually wear dentures. Now, one negative consequence of individuals who wear dentures is how it blocks our sensory system in the roof of our mouth. So for those of us who don't have dentures, when we take a bite of food, there's a sensory system in the roof of our mouth that identifies how big that object should be in order to actually swallow it. So with those dentures, it actually blocks that sensory system. And as a result, if somebody's eating steak or a higher concentration of food, that's where they're much more prone to choke, because they're not able to actually identify that they should chew longer in order to properly swallow it. Then our smooth muscles of our lower airway weaken. So think of our lobes, our bronchioles, our bronchi that are leading down into our alveoli system. With these smooth muscles deteriorating, it makes it very difficult for that oxygen to actually get all the way down into the lower system of the airway, where that gas exchange is taking place. Then we also see quite a bit of buildup of carbon dioxide, because that waste material isn't actually able to get through that respiratory system. Our vital capacity and our residual volume, these both decrease and increase. So our vital capacity is the amount of air that we can actually get inside of our lung system, and that decreases. And so if somebody tries to take a big deep breath, or maybe they're compensating by trying to get more oxygen into their system, they don't have that vital capacity that the younger generation has. And then with residual volume, this is going to increase. So our residual volume is the amount of air that remains inside of our lung system after a complete expiration. So the negative consequence behind this is, again, that waste material is going to be consistently built up inside that system. And then it also interferes with the amount of oxygen that's actually coming into the system. Now, as far as our musculoskeletal system, that helps regulate our respiratory system. We start to see a deterioration of the spine, the ribs, the breastbone, and the diaphragm as well. So here we can see that breakdown too of that alveoli. So on the left, younger population, and somebody who doesn't suffer from any type of COPD, we're going to have that nice shape within that alveoli, which really helps that regulation of that gas exchange between oxygen and carbon dioxide. In comparison to the geriatric population, we can see that the shape, the elasticity, the walls of that alveoli are going to begin to break down. And as a result, we're not getting that great gas exchange that we would see with that younger population. Here, that example of that residual volume. So we can see how much air is still left in that aging lung once that complete expiratory system actually happens. And then the IRV, that's going to stand for inspiration residual volume. So we can see this is the max volume that they can get when they're actually taking that big deep breath in. Next, we're going to talk about our cardiovascular system, atherosclerosis. So this is going to be inflammation of the coronary arteries. So it makes it difficult for individuals to actually regulate their blood pressure, whether they have to constrict due to going into compensation, or if they need to go back into a hypotensive state. We also see a decrease in heart rate. You know, our power plants, our SA node, our AV node, and our Purkinje fibers, they're not going to be working as properly as they should. And if they do need to start compensating, oftentimes their heart rate doesn't get that message for an extended period of time. And that's where they can decrease pretty rapidly when we're looking at that compensated and decompensated shock phase. Our cardiac output, that decreases, so our preload and our afterload, they're not getting enough blood being injected from the left ventricle to the rest of our body. And then also we're not seeing a high quantity of blood volume actually returning into the body, which would be our preload. Individuals within that geriatric population too, oftentimes are susceptible to different cardiac arrhythmias or dysrhythmias. One of the most common ones that we're going to see is something called AFib and or aflutter. So atrial fib is the most common one that we could see with that abnormal rhythm. And so it's an irregular heart rhythm. It is being generated by that top portion of the heart. So that electricity is still flowing all the way through the heart. It's just, it's irregular, it's abnormal, and not everything is basically clicking as it should. They do have the tendency to have pulmonary embolisms. We have those blockages, those thrombosis inside the lungs and inside the cardiovascular system, which can create our heart attacks or our STEMIs. We also see a decrease in change of epinephrine and norepinephrine. So when our body goes into that fight or flight response, it dumps epinephrine and norepinephrine into our system. And what this is going to do is it's going to constrict our blood vessels. It's going to make our heart rate go faster. And again, if somebody's going into compensated or decompensated shock, we have a decrease in that level of epinephrine. And then also the body isn't as susceptible to the changes from those chemical properties. And then lastly, we're going to see an enlargement of that left ventricle, because that left ventricle has operated for so long that muscle begins to build up. And then as a result, the volume that can actually be ejected from that left ventricle actually deteriorates. So now we can see the difference between our younger or healthy heart in comparison to our aging heart from the left to the right. Next, we have the nervous system. The brain actually shrinks about 10 to 20% by 80. So with that smaller brain, all of the different capacities and capabilities of that brain is going to decrease with that shrinkage of 10 to 20%. This does not include individuals who suffer from dementia and Alzheimer's. Alzheimer's, dementia, those are basically fancy terms for that brain shrinking. So we're going to see even greater shrinkages of that brain. We also see a loss of neurons, 5 to 50%. So this is where that change in environment is going to be delayed. So if grandma accidentally touches the stove and it's hot, it's a delayed effect from that sensory system going from her fingers or her hands up through the spinal cord into her brain in order for her to actually tell her to remove her hand away. So that's why we see those traumatic events, those burns and issues like that are substantially higher for a geriatric population because they don't have that defense mechanism that's actually built in like we would see for the younger, healthier adult. We also see an increased chance of that subdural hematoma. So remember our brain bruising, and oftentimes these signs and symptoms are going to be delayed because that blood pooling actually takes a little bit longer than somebody who's younger. Here, really good example of that brain shrinkage between the normal brain section and then the Alzheimer's brain section. And again, Alzheimer's dementia, this is a very common occurrence for a geriatric population. As of right now, there are no medical treatments that can actually stop and or treat this condition. However, there are different medications out there that will actually delay the negative consequences behind it. Now, issue with that is those medications will only work for so long, and then that patient begins to deteriorate as well. Sensory changes, we're going to see a pupillary reaction become restricted. So that dilation, that constriction based on the environment around them, and then also based on that epinephrine, norepinephrine dump is going to change pretty drastically. We also see a thickening of the lens. So for those of us who have had one or too many drinks and we start to get that blurred vision, this is what actually is occurring all the time for individuals who have that thickening of that lens. Everything is kind of blurred at that point. Then we also start to see hearing loss develop, and this is much more common than eyesight. So again, making sure that we're speaking into the good ear or speaking loud enough but cordial enough in order for our geriatric patients to actually hear us. Here we can see that thickening of the lens, and again, makes it much more difficult. And then we can see the thickening of the eardrum for a geriatric population. And this is the chief culprit behind why these geriatric patients aren't able to hear as well as the younger generation. So basically it's a constant earplug in there from that thickening of that eardrum. Psychological changes, what we're seeing, high levels of depression, anxiety, and then also suicidal thoughts, especially with individuals who have lost their spouse and or they're living in a facility and maybe they're not getting the support that they may desire from the family members that are still surviving. Adjustment disorders, this again relates to individuals who are leaving their homes and then entering in some type of institution. So, you know, think of our grandparents, if they are still alive or when they were alive. You know, they lived in a certain house for years and years and years, and then all of a sudden one day they go from living in their house as independent people to living in a small apartment within one of these institutions, and their entire existence, their entire day basically is torn apart from going from one house to an institution. Next, our renal, our hepatic, and gastric systems. Again, these are all going to decrease over time. And with all of these functions, remember how they normally function and what they do for the body, and then correlate to our geriatric patients. So our kidneys, what they do is they filter out the blood, and we see a decrease of 50% in between the ages of 20 to 90. So whatever we intake into our system, if our body doesn't agree with it, our body does have to filter that out and then go ahead and remove it from our system. So if we're not filtering properly, we can see that increased buildup of some different types of toxins. And once those kidneys begin to fail, that's where we're going to see our individuals who receive dialysis treatment, or they actually get that blood in that system actually filtered out for them. Next, with our kidneys, chief thing that these do is actually remove the toxins. And so geriatric patients, I mean, they take quite a few different medications, and not every doctor, not every healthcare facility speaks properly to each other to exactly identify what these individuals are actually taking in the form of medications. And so it takes a while for these individuals to actually remove any excess drugs that are actually inside their system. And then we can also see a buildup of those drugs. So let's say your patient is taking metoprolol for high blood pressure. Now she goes to a visit and doctor takes her off metoprolol because her blood pressure is beginning to decrease, so she doesn't need that medication anymore. However, that metoprolol that she had been taking for 5 years, 10 years, there's still going to be quite a bit of a buildup inside her system. So if she gets put on a different medication, and metoprolol and this new medication work synergistically with each other, we can see that change in that blood pressure, change in some negative effects. Our liver diminishes, as well as the enzyme properties. We see a decrease in saliva. So this makes it difficult for individuals to digest their food. And then also when we do eat, that's the first thing that we do as far as intaking those nutrients is from that saliva. So we're kind of decreasing our ability to obtain some of those nutrients right from the first portion of that GI system. So next we're going to talk about the musculoskeletal system. So with the muscles, with the bones, atrophy basically means the breakdown or deterioration. And so all the muscles, all the bones begin to weaken and deteriorate. Our muscle fibers become smaller and fewer. And so with this, they are much more prone to injuries, muscle tears, sprains, strains, and then also muscle breaks as well. So our ligaments, they lose that elasticity, so we can also see them much more prone to dislocations of their joints from those ligaments actually tearing. Muscle mass, this is going to be replaced by fat oftentimes. And then we also see a lot of osteoporosis for our patients as well. So remember, this is what our musculoskeletal systems does for our body. And again, this is the decrease within that musculoskeletal system. Next, we're going to talk about the immune system. They are prone to infection, and we have less fighting capabilities. We don't see as many white blood cells inside the system as we would for the younger generation. They are very prone to a couple of different viruses and bacteria, which leads to pneumonia and UTIs. So UTIs oftentimes is correlated to dementia, but this is an acute version of dementia compared to Alzheimer's, which would be a chronic version. So with UTIs, we can see a change in mental status based on that high fever. And the reason why we get that high fever when we are sick, oftentimes is we're going to increase that body temperature in order to kill that virus or that bacteria. So this was a relatively depressing slide, but keep all of these different components in mind when we are dealing with that geriatric population. And remember too, this is a large bulk, or a majority of our call volume goes towards our geriatric population. So when we start thinking of EMS operations, we're going to see an increase in individuals who are living beyond 65 and older. So our call volume is going to continuously increase as well. All right, that does it for chapter 39. Thanks, guys.